Okay, so this is what goes in?
Yes, and that is a device that is going to try to accomplish a couple of things. Number one is it will act as a wearable defibrillator performed within the heart, and it will attempt to protect you against arrhythmias that could be life-threatening, and that's the defibrillator portion of the device. But because you have something called a left bundle branch block, it's a specific marker of your EKG that tells me that the contraction within the heart dances like this.
Not at the same time.
Rather than a symmetric fashion. That tells us if we're able to put an extra cable in a blood vessel called the coronary sinus, it's a specific vessel that wraps around the heart. If we're able to put that extra cable in a position in which we're able to synchronize your heart, that would, number one, strengthen your heart muscle, and number two, improve your symptoms of heart failure, which includes the fatigue, the tiredness, the shortness of breath. It's an inpatient procedure in the sense that we bring you the morning of the procedure, nothing to eat or drink after midnight. You spend the night, non-negotiable. I want to make sure that, number one, we assure that you don't move this arm, and we'll check those cables. The day after the procedure, we'll check the device, we'll check some x-rays. But the way we do this device, make an incision about this size. And you're right-handed or left-handed?
Right-handed.
So we tend to put it in the left, and I'll explain to you why in a second. But make an incision about this size where the device will fit. And we go in and make a small pocket underneath the skin. And this is while you were very asleep. We use medications to make you very comfortable. Then once we make this pocket, we go in with a needle and get this vein called the subclavian vein. And through that vein, you put all the cables down into the heart. So as you know, those veins communicate with the heart. And there's a video that I want to make you watch as well. But we put these cables in the different positions, and specifically the right ventricle, the right atrium, and the LA cable that's going to attempt to wrap around the heart and synchronize your heart. So what we do next, we attach these cables to the surface of the muscle, and then we plug them into this part of the device. We put this inside, and we close the wound.
So it will stick out above my muscle?
It will be between your skin and above the muscles, below the skin and above the muscles, something called a fascia. So it's right below it. So the easiest way to know whether you're going to feel it or not is probably look at something like this, and this is what you'll feel. But you have to understand this
There
is
goes my modeling career. No, just kidding.
It's a life-saving device, so that's the only important thing.
The heart, the wire around my heart won't tangle or strangle the heart?
No. So we're talking about spaghetti wires. They're very delicate. They're very flexible.
Okay.
So, and it's actually in a blood vessel of the heart. So the easiest way to understand it is think of it as like a little bit of tape in that area. So it would not restrict the way the heart moves. Just sort of an electrical synchronization.
So this is a little bit more than just putting a defibrillator.
Correct. Which is a good thing.
Okay.
If your QRS or the specific marker was narrow, then the device would only be there to protect you. It would not improve your heart failure symptoms. But because you have the left bundle, I think it's likely that this device will make you feel better.
Awesome.
The chances are probably between 75 and 80% based on the studies that have been published. And again, it's depending on where we put this cable and the other variables that we have during the procedure, but it's likely that this device will make you feel better. The odds are in your favor in that perspective. So once the device is in, I'll give you a medication that's going to make you completely asleep for about 20 seconds or so. And we test this device, which means this device will put you in the bad rhythm, and this device will bring you back to the bad rhythm.
Okay.
The reason why is we want to make sure that this device is going to work when we're at work.
Right.
And that's something that we do routinely.
Am I going to be sore the next day from it?
No. Well, from the device itself, well, you understand, you're going to have surgery. So there's going to be an incision. We're going to do a lot of pain medications, and it's going to take about 2 or 3 days for things to normalize.
Okay.
You go home the next day after we do an x-ray, make sure that there's no air pocket, the cables are in a good position. We check the device to make sure the energy requirements from all the cables have remained stable. And then I'll send you home with a sling. And the reason I want to wear you a sling is because I know my patients. So make sure that you don't move this elbow and this stays stable for approximately 7 days. Because you would imagine these things will be attached to the surface of the muscle.
Right.
So if you move this muscle,
it's going to come up
prematurely, that could cause those cables to move out of place. And you won't be happy and I won't be happy. It means they're going to have to go back in and reposition them.
I did hear of a lady that had a defibrillator and she worked out well after it was put in, and she tore a cord in there, and it was just when it stopped vibrating and they had to replace it.
Well,
Is that going to happen later?
There's some mechanical issues related to that. One of the things that I don't want you doing is bench pressing too much of a weight, and the reason why is you would imagine that this interaction between the muscle and the blood vessel is relatively close. So I don't want you to get big pectoral muscles, basically.
No, I don't either. They're already big.
But most of the times mechanically these things go well, and as long as we maintain the limitations in the arm movement for the next 4 to 6 weeks, things should heal appropriately.
Okay.
Okay. So once this device is in, I want to see you between 3 and 6 months to follow up on the device. As you know, this device will tell me what your heart has been doing, how much have you been using this device, and is there something that we ought to do to improve your symptoms and all that.
Okay.
Now, you didn't ask me a battery. How long does this device last?
I was going to ask.
Yeah. So the battery is directly dependent on how much you use it and how much amount of energy does the cables need to stimulate your heart. But the average is probably between 7 and 8 years.
Oh, okay.
And the way we change the battery is relatively simple. We go in and we open up the wound, take the device out, take these cables out of the old device, give you the new device, plug them back in, put them back in, and close the skin. So it's a relatively simple procedure. And 7, 8 years from today, whenever you get your new device or your next battery, the devices are going to be smaller, smarter, and that's sort of a good thing that we have, that we can update this technology in the future.
I do have a question.
Mm-hmm.
They taught me when this goes off, when it monitors if my beat gets a little erratic, I need to keep stopping it, because she said I want to be knocked out when I get... How is that going to know if I'm passed out or not? Or is it going to kick in when I'm awake?
Well, it's a good question. The majority of the patients who have this arrhythmias and they receive a shock, they're either about to lose consciousness or lose consciousness. We can program this device to delay the shock unless a specific criteria is present. Make sure that you don't receive any inappropriate shocks and things like that. But if you go into the malignant arrhythmia, ventricular fibrillation, and it's lasting more than the specific time, we don't tend to fool around. We want to make sure that this device brings you back to life. And unfortunately, shocks are not comfortable.
I was going to say, because this thing goes off on me all the time, and I know it's just maybe my heart beating a little bit faster or something, but I have to turn this thing off a lot, and I'm almost like panicked because I don't want to get shocked.
And you understand that this device is not perfect either.
Okay.
This device will have specific cables within the heart, so it's the best way to monitor your heart rhythm, because there's nothing better than being within the heart to monitor the electrical system.
Gotcha. Okay.
But there's some criteria that we use in something called anti-tachycardia pacing, which means if you go into an arrhythmia and the arrhythmia is stable enough, in the sense that it's not as fast as ventricular fibrillation, for example, this device may try to break it without having to use a shock with a specific pacing protocols that we have. So there are maneuvers that we use to try to minimize the shocks.
Okay.
But if you were to a point in which you were in an arrhythmia called ventricular fibrillation, and it's lasting more than the specific setup that we determine, the device will shock you, and this is what we want to accomplish. We want you here with us.
Okay. Okay.
Which makes sense. This is just a lot
Smarter.
smarter than this.
Yeah.
Is just an emergency, and this is going to be.
Yeah.
It's going to be able to tell more so than that thing will.
Yeah. The reason we brought you to clinic earlier, because I know you had an appointment
On the 18th? Yeah.
Brought you early because I went through your chart and I knew you were wearing that defibrillator, so
Thank
I
you.
wanted to maximize the time so we take that torture device out of
Thank you. I wrap every night. It wraps around me and it goes off because it loses the sensor, and it's like, thank you so much.
Yeah.
So with this, you said it's going to be pretty much. It's going to strengthen her heart to where she's not always tired.
That's the hope.
That's-
That it will lead to an improvement in her heart muscle function and an improvement in her symptoms of fatigue, tiredness, and shortness of breath.
Thank goodness.
I don't think that this device will allow us to stop medications though,
Right. I
but,
know.
but will allow us, number one, for more room for medications. And second of all, the thing that we've noticed is patients tend to use less diuretics,
Oh,
less Lasix once the heart muscle function improves and all
because it's
that.
pushing the fluid better, right?
Yes, but coming off the beta blockers and coming off the ACE inhibitors, the other medications that you have, I don't think we're up to that point yet.
And because I work with a personal trainer, I will be in contact with you of knowing what I could do and what. Can I bring him with me if he wants to come so you could tell him what I can do or not?
Absolutely, yes.
Okay.
No, well, the important thing is after 6 weeks pass, you should be able to do everything you want to. There
Okay.
should be no restrictions. The only thing is,
Is these
I don't
ones?
want you bench pressing because that would create a significant amount of stress in that junction. We tend to put them in something called the axillary vein, which is in this area. There's something called the subclavian vein, which is in this area. So we tend to avoid puncturing this area more towards this area, so there'll be less friction. But again, it all depends on how good that vein is and how big of that vein vessel is and all those things.
Okay. Okay. So now the question is when?
Let me examine you, and I'll bring Melanie. She's my nurse. She's basically my boss. So she'll find a date that works for both of us. But I wanted to bring you early to clinic so you don't have to
Thank
wait
you.
too much.
Thank you very much.
No problem. And I'll make you watch that video too.
Okay.
Take a deep breath. Okay. Questions?
The cable in your that is gonna be in her that are gonna be in there, is that what would actually do like the shocking and stuff like that?
Yeah,
So that's just like the battery and the brains and stuff?
Well, there's a vector, and if I were to graph you what this thing will look like. So we got the vein, through the cable's gonna go. So there's one cable called the defibrillator lead,
Okay.
which has something that we call a coil. There's gonna be two coils, one here and one here. There's gonna be one lead called the right atrial lead, which is gonna be in the upper chamber.
Okay.
And there's the other one that we call the coronary sinus lead that's gonna wrap around and try to stimulate her heart in this area.
Okay.
This, and the can is what gives the shock.
Okay.
So the shock is actually, and there's different vectors that we can do, but most of the times what we do is this and this. So this is what's gonna provide the energy. So it's a combination between this and the coils.
Okay.
Okay.
I was just wondering why it would go on the outside rather than on or near the heart itself.
Oh, it's because of the specific vector we want to
Right,
accomplish.
okay.
So that's why putting on the left is the ideal, because of, as you know, the heart is a left-sided structure.
Right.
So that way we'll provide us better coverage of that region.
Oh, I see. Okay. Okay.
Okay. No matter what we do, talking about the risk, no matter what we do, there's always the risk of pain. There's always the risk of bleeding, and the bleeding could be in this area or could be within the heart. They're both very rare. You're not on any blood thinners or anything that would increase that risk. There is the risk of one of these small cables poking a little hole in the heart. That's very rare. But if it does happen, what could potentially happen is your sac of the heart will get filled with blood. And that blood will need to come out. What we usually do is put a needle and drain that blood.
How will I know if it's doing that?
No, we'll do it during the procedure, and again, it's extremely rare, but if it does happen, we're ready to deal with it.
It only happens when you're doing the
Correct,
procedure.
yeah.
Oh, okay.
Correct.
Okay.
It will manifest as a drop in your blood pressure and all those things that we're ready to deal with. No matter what we do, is the risk of infection. That's why you're going to get antibiotics before and after the procedure to minimize the risk of infection. We're going to be very careful the way we handle this wound, and I'll give you all the indications after the procedure, what to do, what not to do. We're going to be seeing you very frequently in clinic. to follow up on the wound, but that's about it.
Okay.
Okay?
Okay.
Let me bring the boss and then we'll get a schedule.
Okay, thank you
Okay.
very much.
Mhm. Nice to meet you.
Nice to meet you, thank you.
Thank you so much.
Thank you.